Identifying those who would benefit from palliative care is a significant barrier to providing timely palliative care. How can we automate the timely identification of patients who might benefit from palliative supports? Our team developed the Hospital Patient One-year Mortality Risk tool, called HOMR or mHOMR for short. It's a tool that uses data available at hospital admission to predict risk of death in the next year. We work with hospitals to develop a tailored implementation plan in 4 phases. First, we conduct a needs assessment. We create an implementation team at each hospital and assess resources and needs through focus groups. Next, we integrate HOMR into the electronic medical record. We determine technical logistics with the information system technology teams and work with clinician educators to educate staff about the HOMR tool. We then test the HOMR tool, and HOMR is in go-live mode, meaning it is actively identifying patients who are at increased risk of dying in the next year. We conduct chart reviews and interviews to see if the HOMR tool is actually making a difference. Lastly, we share learning between sites to identify best practices for integration. When a patient is flagged by the HOMR tool, clinicians are prompted to do 3 things. First, conduct a symptom assessment. Second, conduct an advanced care planning assessment. And third, to address unmet palliative needs. HOMR is accurate and acceptable to patients and providers. It is integrated into the electronic medical record, and it is both prospective and works in real time. 11 hospitals have implemented HOMR, and 5 more are in the process. Data from 6 of these sites shows that before HOMR implementation, 68% of patients had a documented symptom assessment. After HOMR implementation, this number changed to 85% of patients. Data from the same 6 sites shows that before HOMR was implemented, 28% of patients had a documented advanced care planning assessment. After HOMR implementation, that number jumped to 53%. Our results show HOMR significantly increased the proportion of patients who received a symptom assessment, an advanced care planning assessment, and a goals of care discussion. Interestingly, over 55% of HOMR patients who completed a symptom assessment had a severe, uncontrolled symptom. This suggests the HOMR tool is helping us identify suffering that was previously going unrecognized. After HOMR was implemented, significantly fewer HOMR patients died in hospital. This was accompanied by significantly more HOMR patients who went to a long-term care home or continuing care facility, such as an inpatient palliative care unit. Though HOMR improved documentation of palliative needs, there were no changes to the proportion of patients who received a specialist palliative care consult or specialist palliative home care. This suggests that many palliative supports can be delivered by non-palliative care specialist clinicians. Overall, HOMR is a feasible, effective, and scalable tool for identifying patients with unmet palliative needs in hospital. It is also feasible, effective, and scalable for prompting clinicians to assess for uncontrolled symptoms and readiness to engage in advanced care planning. More HOMR implementation means more patients admitted to acute care hospitals in the last year of life will have palliative needs assessed and addressed. To learn more, please visit www.homerinitiative.ca.